Good afternoon, dear colleagues. I already heard some discussion about fixation, and actually there is a lot of information already on impact of individual steps in paraffin-embedded tissue processing on biomarker preservation. However, this is not the case for cytology sample processing. So today I will present you what do we know about biomarker preservation using different ancillary methods, and for this purpose I will use results of two recent surveys performed by European Federation of Cytology Society about immunocytochemistry and cell blocks. I will also use some results from external quality assessment of ICC on cytology samples UK and EQUAS, and I will also present some of our experiences. So according to this ICC survey, we can say that ICC is extensively performed in European laboratories with an average number of yearly performed ICC approximately 1,500. And as you can see, majority of participants or laboratories perform ICC on one of the available automated platforms. It's interesting that the frequency of using different cytology preparation is more or less equally distributed between cytospins, direct smears, cell blocks, and liquid-based cytology slides. What is even more interesting is that more than half of laboratories use not only one, but a combination of 2, 3, or even 4 different cytology preparation for ICC. And the most important is, of course, demonstration of variability in fixation, or perhaps better say fixatives used for cytospin smears and liquid-based cytology slides. Majority of laboratories use formalin-based fixatives for cell blocks, but not only variability in fixation, we were able to demonstrate also variability in post-fixation steps and storage of ICC slides before actual staining. And all these steps, not only fixative, but perhaps also time of fixation and post-fixation and storage of slides, can very importantly affect on final results. So the natural questions at these points are: which are optimal slides, or what is optimal slide for ICC? What is optimal fixation? What are the differences in ICC quality and reliability? And are the cell blocks really the best option for ICC and all other ancillary methods? In order to answer these questions, I will use examples and images from UK and EQUAS assessment for Run 108, where the slides, cytospins and cell block sections prepared from a mixture of human melanoma cell line, effusion with carcinoma cell and some mesothelial cells, and also lymphocytes from lymph node FNAB. So from this mixture, cytospins and cell block sections were prepared and sent to participants with request to demonstrate CD45 and one of the melanoma marker. And here you can see results received from different laboratories on the NEQUAS cell block. Here you can see this is for CD45, and here is the reference or gold example. And I hope that you agree with me that there is great variability in quality of ICC between different laboratories. Some of them achieving great results, but it seems that some of them have some problems. And the same variability can be seen also on cytospins prepared from the same cell suspension. Again, some laboratories with great results, good quality, and some laboratories having problems with non-specific staining and background staining. And here you can see, because in NEQUAS, we asked participants not only to send NEQUAS slides with demonstrated antigen, but also in-house slides. In this case, in-house cell blocks with CD45 demonstration. And again, you can see that not all laboratories achieving good quality. And again, the same variability can be seen on in-house cytospins. So the final conclusion of this can be that actually good ICC quality can be achieved on a differently prepared and processed slides. And here you can see CD45 demonstration on cell block, formalin fixed, paraffin embedded, on a smear fixed in ethanol, and on cytospin fixed in methanol. And I think this is very important. So it's not only fixation, but all different pre-analytical factors can affect the final result. But not only this, it is also necessary to adjust analytical part of ICC in order to achieve good results. The only fixative which was found not suitable for ICC, at least in UK NEQUAS, was acetone, mostly because of very poorly preserved cell morphology. And here you can also see a comparison of ICC reaction on cytospins, methanol fixed cytospins, and corresponding tissue cell block. And you can see that you can achieve good results on cytospins as well as on cell blocks. So processing of cytology samples for ICC is not standardized, and there is great variability in all aspects of ICC on cytology samples. However, good ICC quality can be achieved on a differently prepared slides. The question is, of course, how reliable are these results? And because using or in application of ICC on cytology samples, we have to consider that all commercially antibodies were designed and prepared to detect epitopes in formalin-fixed paraffin-embedded tissue samples. So, and each modification, each variation from this standard procedure should be optimized and validated. Optimization means that we have to adjust, optimize steps in ICC staining procedure in order to achieve best ratio between specific and non-specific staining. And it's very important that ICC protocols are not exactly the same as protocols for tissue samples. Here you can see analysis or comparison between ICC and IHC protocols from our practice for almost 40 antibodies. And there are differences in several steps, of course, in antibody dilution, in pretreatment and deparaffination, which is not necessary, of course, for methanol fixed cytospins. And similarly, that ICC protocol are not exactly the same as IHC protocols was reported by Sauter and her colleagues, for example, for salient cell blocks, where it is also necessary to adjust IHC protocols for majority of antibodies. So validation means that we have to confirm that the test works as expected, as it intended, and for ICC on cytology samples, we usually do this by comparing results with corresponding tissue samples or any other reliable and appropriate method. So I will, because there is not a lot of information about validation in the literature, I will present you our approach. First, I would like to introduce to you our sample processing procedure, where we all leftovers of sample from the needle, we suspend it in a buffer-based cell medium after preparing smears for cell morphology. And similarly, we prepare controls by brushing of fresh resected tissue. We suspended these cells again in cell medium, and then we can prepare from this cell medium, we can prepare cytospins for different ancillary methods. We can also prepare cell blocks. We can use this cell suspension for flow cytometry or even for molecular tests. Even one of the main reasons for using this approach is also that we can easily remove erythrocytes from heavily hemorrhagic samples using simple filtration. So we physically remove erythrocytes or separate erythrocytes from epithelial cells, so we can achieve deposition of cells on the slide without erythrocytes. Our first validation study was, I think, 30 years ago, first for CD markers, where we compare ICC results with flow cytometry results for different CD markers. And at this point, we determined that air drying of slides before or after fixation have a detrimental effect on all CD markers. So in all our next future procedures, we omit any air drying before or after fixation. Second big validation was done for Ki67, where we compare ICC results with S-phase fraction determined by flow cytometry. And the biggest validation study was performed for hormonal receptors, where we performed 4 independent studies in order to first to define or to design optimal combination of pre-analytical and analytical steps to get expected results. And then we confirm this combination of factors on ex vivo FNAB samples. And of course, we compare ICC results with corresponding tissue samples. And all these studies were already published. But of course, it's not possible to perform such extensive validation for each and every marker, and for the rest of the markers which are not so demanding, we just confirm correct immunoreactivity on methanol fixed cytospins. And finally, we validate our procedure by comparing ICC on methanol fixed cytospins with IHC on concordant tissue samples for 50 diagnostic routine cytology samples, and we achieved a very high concordance. So we are sure that our results are reliable. And with all these efforts, we were able to improve our ICC from such results on direct smears to the better results on methanol fixed cytospins. So great variability in all aspects of ICC are definitely reality, and good quality can be achieved on a differently prepared slides. However, it's mandatory to use appropriate quality assurance, quality control measures, such as control slides prepared in the same way as patient sample, proper optimization and validation, and of course participation in external quality control service. So are the cell blocks really the best option for cytology samples? So in order to at least know what is reality in European laboratories of using cell block preparation, EFCS was performed survey about cell blocks, and here you can see results. And majority of laboratories use just embed naturally occurring clots or tissue fragments in cell blocks, followed by still very popular plasma and thrombin, as well as agar method, while Shandon cytoblock, histogel, cell scrape, and Celient are used less frequently, and some other exotic methods even rarely. So what is important in this survey was that we found that low cellularity is the main issue with cell blocks in daily cytology practice. And this is exactly the same found by Crapanzano and his colleagues with the survey among American laboratories. And we also wondered, are there any differences between the frequency of individual issues with cell blocks regarding the preparation methods? But as you can see here, there is very little variability in the frequency of reported issue regarding different cell block preparation method. And I will also like to show you results from our study where we evaluated relation between the number of embedded cells with the cell block cellularity. And here you can see H&E sections prepared from aliquots of the same sample with different cellularity. And this is a nice demonstration of our final results. Confirming that in order to assure an adequate cellularity of the cell block, you have to have at least 1 million of cells. And here you can see cell block and H&E sections prepared from different samples with different cellularity, high cellular, medium, and low cellular sample. And what is interesting is that even in low cellular sample, you can prepare an adequate cellular cytospins, or at least few of them. And another nice demonstration about the differences between cytospins and cell blocks from our recent practice, where we prepared 60 cytospins and the cell block from the same cell suspension for CD45 demonstration, and all 60 cytospins were adequately cellular, while cell block prepared from the same cell suspension was suboptimal cellular. So conclusion regarding cell blocks, there is again great variability in cell block preparation method, and low cellularity is the main issue with the cell blocks in a daily cytology practice. So obvious recommendation would be that low cellular samples are just not suitable for cell blocks embedding, and that is probably necessary to somehow select eligible samples for embedding. So what about molecular testing on cytology samples? There are several reports already that cytologic specimens are even better than formalin-fixed paraffin-embedded tissue for molecular testing because formalin causes degradation of DNA. and that various types of cytology preparation are better than cell blocks, but it's, of course, again, necessary to validate and adjust procedures. And even more, archived MGG and Papa Nicolau stain slides having at least 100 of tumor cells are suitable for NGS. Here are reports. Here are reports from the recent International Congress, Cytology Congress in Baltimore, confirming the quality of nucleic acid is better in cytology preparation than in tissue samples, and that Papa Nicolau and MGG stain smears yield enough quality DNA and RNA for NGS. And example from our practice where we performed NGS from ultrasound-guided FNA of liver tumors, and we were successful in almost all cases. For isolation, we use fresh cells from our cell medium and stain smears. So we can conclude that and probably it's not impossible to actually completely standardize cytology sample processing in the same way as it is standardized for tissue samples. But at least we know that we can achieve good results on a differently prepared cytology samples with proper optimization and validation. The results can be very reliable. Thank you very much.